Hello, and welcome to episode 10 of Opt to Thrive. When he's having trouble pitching a tent, what you need to know.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
Hello, and welcome to this episode of Opt to Thrive. It is a little bit blustery out there. I'm not sure if you're going to hear some of that wind today or not, but it's pretty blowy out there. It's 26 degrees, I think, today, which is just ridiculous for this time of year. I'm looking right out the sunroom window today, and it's pretty spectacular. There's all kinds of blossoms going on about there. There's a tree out there. I think it's an ornamental plum, and I swear to you, yesterday it had nothing, and today it is full of blossoms. My rose bushes that I, took a little chance on, never pruned a rose bush in my life, but got some advice, as I said before, from my hairdresser and a little bit of YouTubing. And yeah, they're already full of leaves. So I'm thinking we're going to see some beautiful roses soon. Really looking forward to that. That would be just in time for Rose Week here in the Riverland. We have Rose Week every October, and I think not that anyone's going to see my roses. But yeah, I think that they'll be on show, at least for me. So today we're talking about erectile dysfunction. In the old days, it was called impotence, and it's defined as a man's consistent or recurrent inability to attain or maintain an erection sufficient enough for satisfactory sexual activity. But wait, isn't this a midlife women's podcast? Well, yes, it is. But bear with me. Let me explain my reasoning, and I have got a few reasons. So first, if you have a male partner and he's having issues, then the carry-on effect is very likely in some way affecting you or your relationship. It can cause a great deal of emotional damage to him and to you and have a significant impact on the quality of life. Second, if this is happening for them, there could be some serious underlying conditions that need to be looked into, which is very closely linked to my reason number 3. I know from experience that most men need to be about half gone before they find their way to the doctor. They're often forced or nagged. I'm using some air quotes here. I'm not a fan of that word, but nagged into going to the doctor. So they go and see the doctor, and often when they do see the doctor, they're too embarrassed to bring this up. So many times it's a worried partner that raises the alarm bell and gets them to do something about it. And look, I am all for people taking responsibility for their own health. As you probably have picked up by now, that's why I'm doing this. I want you to have the knowledge to empower yourself to make those health choices and decisions for yourself. But you don't know what you don't know. And if you know and you let them know, then they might get onto a serious condition sooner rather than later, or at any rate, get some treatment, because this condition is almost always treatable. So how common is it, I hear you asking? Well, erectile dysfunction is fairly common, maybe more common than you might expect. So let's just put it into context in terms of how common it really is. One Australian study looked at just over 108,000 men over the age of 45, and they found that it affected 61% of them. So well over half of the men in that study. In 25%, it was mild, 19% somewhere in the middle, and then there were 17% that had complete erectile dysfunction. Now, most sources I've read have put the rates at around 50% of men by the age of 50. So I think that's kind of an average figure. That's half. Now, the good news is that if we can get onto this early, we have an opportunity to change the trajectory of a man's future health and well-being. And if that's someone that we love and plan to grow old with, then it's in our best interest really to try and help support and protect them the best that we can. And one of those ways is empowering ourselves with knowledge and then passing that knowledge on to them, because it's very unlikely that most men are probably looking for a podcast about erectile dysfunction. Now, The causes can be multifactorial, so meaning that there are often a few things happening at once. The causes are broadly split into two categories. So you've got the psychological category, so related to thinking or mental health, or you've got organic causes, so related to some type of underlying physical condition. And as you can imagine, the two can be really quite difficult to disentangle, kind of like the chicken and the egg. Did the erection problem cause the anxiety or depression or relationship issue, or did the anxiety or depression or relationship issue cause the erection problem? Generally speaking, there are some things that you can look for that might point towards a psychological cause. So if it happened really quite suddenly, and he's otherwise physically well, and if he hasn't hurt his back or had a stroke or something like that, especially if this is a new relationship, so it could be performance anxiety related, nerves, or if there's been some kind of major life-changing event recently. If it only happens in certain situations, if he gets normal erections with masturbation, or if he gets those good morning erections, then it's likely to be some kind of psychological problem that's causing the trouble for him. Earlier, I alluded to the fact that this problem can be related to some serious health conditions. And there's one in particular I really wanted to highlight today, and probably really the main reason for me talking about this issue. What we know is that erectile dysfunction can be the first symptom of otherwise silent cardiac or vascular disease. Now, part of the reason for this is that the arteries that supply the blood to the heart and the arteries that supply the blood to the penis are similar in size, and they are very similar in how they can develop atherosclerotic plaques, or hardening or thickening of the walls of the artery. And that's what happens in cardiovascular disease. And since the arteries to the area of the penis responsible for erections are small, they can develop blockages from these atherosclerotic plaques earlier, in fact, years before they show up around the heart. Some sources estimate that erectile dysfunction shows up about 3 years before heart symptoms do. We also know that erectile dysfunction has a similar or greater predictive value for cardiovascular events, so heart attacks, than traditional risk factors like family history of heart disease, smoking, diabetes, high blood pressure, or cholesterol. So if we can get in when this first starts happening, we can look for existing heart disease then and start treating other risk factors to reduce the risks, which can be life-saving. Now, what we also know is that about 28% of men with erectile dysfunction also have diabetes that hasn't yet been diagnosed. If a man is over 50 and he has diabetes, he's roughly twice as likely to have erectile dysfunction than those without diabetes. And the longer he has diabetes and the more severe it is, the greater the risk of erectile dysfunction. So, if we know he has diabetes, we can treat it. If a man knows he has diabetes and that it can affect his erection, he's more likely to be compliant with treatment. Now, another thing that can cause erectile dysfunction is chronic alcohol use. Alcohol can cause nerve damage to the nerves that play an important role in achieving and sustaining an erection. This nerve damage, we also call that neuropathy, affects the communication between the nervous system and the blood vessels in the penis. These nerves signal the blood vessels to widen, increasing the blood flow into the penis, which forms the erection. When alcohol damages these nerves, the signals are affected, causing erectile dysfunction. The alcohol can also cause damage to the blood vessels on their own right, which can then also affect how they function. We also know that excessive alcohol can also worsen psychological problems like depression and anxiety because it's a depressant. And that can put strain on the relationship, and all of these things can increase the risk of erectile dysfunction. We also know that excessive alcohol use can affect the liver, which can then increase levels of estrogen. We've talked about that before, how we have testosterone, they have estrogen. They're not just limited to that sex. And so the way that this mechanism works, they can end up with low levels of testosterone. Low testosterone can lower the sex drive or the libido. It can affect bone and muscle mass and hair growth. Now, I think most people are pretty aware of how much alcohol they can consume and still be under the legal blood alcohol limit to drive. But I'm not sure how many of us are clear about the amount of alcohol we can consume before our drinking starts seriously impacting our health. Current recommendations to avoid health impacts are the same now for men and women. It used to be different levels for men and women, but now across the board, the recommendations are that we drink no more than 10 standard drinks in a week and no more than 4 in a day. So to give you an idea of what that might be, because a lot of people, I think, are not overly clear on what constitutes a standard drink. And this is a little bit different depending on the country. It varies slightly. But in Australia, a full-strength can of beer is 1.4 standard drinks. A midi or a mid-strength can of beer is 1 standard drink. 100 mils of red wine is a standard drink, as well as 100 mils of white wine, which is actually 0.9 of a standard drink, so almost a standard drink. Champagne, 150 mils, which is a standard flute, filled kind of right up, would be 1.4 standard drinks. Now, another thing that can cause erectile dysfunction are certain medications. So as a GP, one of the things that we often look at first when there's a health complaint is the medication that a patient is taking. Are any of the medications either causing or exacerbating the problems that the patient's had? So there should be a medication review. And I'll just kind of quickly go through some of the medications that can be affecting erectile dysfunction. So some of the more old-fashioned drugs used to treat high blood pressure can cause this problem, in particular beta blockers. Digoxin, which is an old-fashioned medication used to treat atrial fibrillation. So atrial fibrillation is an irregular heartbeat problem. It's still used, but there are other drugs that are used more commonly now. And I guess what I'm getting at here is that often these things can be changed to another class of medication that doesn't have the same impact. Sometimes not, depending on a past history, but it's definitely worth having the discussion with the doctor. Some medications that are used to treat an enlarged prostate, some drugs that are used to treat prostate cancer can cause erectile dysfunction. Some medications used to treat anxiety and depression or other psychiatric conditions. Some medications used to treat ulcers and opiates, which are a strong painkiller. All of those things can have an impact on erectile dysfunction. When we treat someone with this problem, the very first thing we do is look at modifiable risk factors and what we call related comorbidities, so other problems that they present with at the same time. We first look at a patient's lifestyle, and we look at things like smoking cessation, because what we know is that smoking is a major risk factor for heart disease. And we know that what the literature shows in men who smoke and quit, erectile quality improved by 25% after 1 year. We look at diet and exercise, as we talked about alcohol and the importance of reducing an excessive alcohol intake, avoiding recreational drugs, weight loss. So if a man is obese, he's 50% more likely to have erectile dysfunction than those who are at a normal weight. And there's evidence that by losing weight, they can resolve their symptoms. And then those other risk factors for heart disease, so blood pressure, cholesterol, and diabetes, we make sure that we screen for those things and we treat them if they're there. Now, in terms of treatment for erectile dysfunction outside of the lifestyle modification, if the doctor is suspicious of a low testosterone, they might test for that and treat for that. That would be a reversible cause. If it's a psychological problem, then we would be referring them for psychological treatment. In terms of medications that can be used to treat erectile dysfunction, first-line therapy are called phosphodiesterase type 5 inhibitors. So as I kind of touched on before, the mechanism of an erection is that a man would have some type of a sexual stimulus which would trigger the nervous system, which then affects the blood flow to the penis. And it actually increases by 20 to 40 times. As areas of the penis engorge with blood, the veins that normally allow the blood out of the penis are compressed, and they keep the blood in the penis, which maintains the erection. And so these medications work by boosting a chemical in the body called nitrous oxide, which allows more blood to flow freely into the penis so it can get in there and maintain an erection when a man is aroused. Two of the most common medications we use would be things you've probably heard of. So Viagra, I think most people have heard Viagra. It's a very popular medication for this reason. And just a little bit of a myth buster, it only works if a man is aroused. I have been questioned asking, is there a concern that I would get an erection and it would stay erect for hours at a time? That's a problem if that happens, and it's a very rare problem. I'll talk more about that in a second. The man can take Viagra anywhere from 30 to 60 minutes before sexual activity. The peak effect is at about an hour, and it lasts for 4 to 5 hours. The other medication that's pretty popular is Cialis or tadalafil. Viagra is sildenafil, and Cialis is tadalafil. This one's taken before sexual activity, but it can take maybe a little bit longer than Viagra. The peak effect is at about 2 hours, but it can start working, I've read, anywhere from about 16 minutes. This one actually lasts for 36 hours, where Viagra, as I said before, only lasts kind of 4 to 5 hours. So that's one big difference. They're both similarly effective. Viagra is 84% effective. Cialis is 81% effective. As I said before, they both only work if a man is sexually aroused. With Cialis, food doesn't affect the activity, but it can affect the effectiveness of Viagra. Side effects for both of them are very similar: headaches, feeling flushed, heartburn, nasal congestion. With Viagra in particular, they could get abnormal blurry vision or blue tinted vision. And with Cialis, one side effect that's common to Cialis but not to Viagra is backaches and muscle aches. Now, as I said before, it's a problem if a man gets an erection and it's persistent. So there's a condition called priapism, and this is where the erection won't go away on its own. So the blood flows into the penis and it gets trapped and it won't drain out. It can be painful, it can damage tissues, it can even disfigure the penis. If an erection lasts for longer than 4 hours, then he needs to go to an emergency room to see a doctor ASAP. Not to worry with these medications, though. It's very rare, as I said before, and it accounted for only 0.7% of the adverse events reported for this class of drugs. Other side effects like headache were much more common. It's really important to note these medications shouldn't be taken with nitrates, which are medications used to treat angina, which is heart pain, because it can drop the blood pressure dangerously low. So as a general rule of thumb, nitrates shouldn't be used for 24 hours after Viagra or 48 hours after Cialis. People who shouldn't be taking Viagra or Cialis are people who are using a topical nitrate. There's a patch that some people wear if they have heart disease to keep the blood vessels around their heart open. So if they've got one of those on, they should not be using Viagra. If they've got severe congestive heart failure, unstable angina, so that's angina without a cause, it just kind of comes on out of nowhere when they're maybe at rest doing nothing. Or if they get angina with sexual intercourse, then it's probably going to be recommended that they avoid intercourse, unfortunately. If when they're at rest, they have hypotension, so really low blood pressure, if they've had a recent stroke or a recent heart attack, then these are all reasons that they shouldn't be using Viagra. Some second-line therapies I'll just mention are penile injections of a medication that can help with erections, and then another one is a vacuum erection device. If these all fail, then they're going to need a referral to a urologist to look at other options. So look, I hope that was interesting and helpful. If 50% of men at the age of 50 are suffering from this problem, then I think a lot of my sisters have partners who are suffering. This is something that most people probably don't share outside the bedroom. So I am hoping that this information can be helpful in getting him to the doctor to look at, as I said before, all those risk factors and manage them to make sure that we are protecting him as best we can from heart disease and all the things that can happen with that. Thank you for joining me today. If you've enjoyed the podcast, please rate, review, and don't forget to subscribe. Share it with someone you think might be interested or might get some benefit from this. Have a great couple of weeks, and until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts her medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.